Hello and welcome everybody to Thermographic Diagnostic Imaging and Health Through Awareness first webinar. We're pleased to have so many people joining us. My name is Getson and I will be your host. Before we begin, just a little housekeeping. The presentation will be about 50 minutes, followed by 10 minutes of Q&A. To the right of your screen, you'll see a chat box. If you have a question, type your question in there and submit it. We will get to as many questions as possible at the end. You should be able to hear the speaker as well as follow the PowerPoint presentation on your computer. If for some reason you get cut off, you'll be able to log back on to the beginning. Then there's a fast forward button that you'll use in order to try and catch up. If for some reason you cannot get back on, don't worry, all the presentations will be archived. Okay, so let's get started. Our speaker this evening will be Dr. Philip Getson. Dr. Getson is a board-certified family physician in practice since 1976 in New Jersey. He is an internationally recognized expert in the diagnosis and treatment of reflex sympathetic dystrophy and has lectured extensively on the subject. He is an assistant professor of medicine and neurology at Drexel University Hospital in Philadelphia. Dr. Getson is also a board-certified thermologist and has reviewed more than 15,000 thermographic studies of the breast, thyroid, and neuromuscular system. Dr. Getson personally reads all of our images, interprets them, and generates all of the reports for thermographic diagnostic imaging. Dr. Getson presently serves as the Vice President of the American Academy of Thermology. Tonight, Dr. Getson will be discussing the latest statistics regarding all forms of diagnostic breast screening, entitled The Good, the Bad, and the Ugly. He'll present some startling statistics regarding breast cancer diagnosis and misdiagnosis and how to maneuver your way through the medical and insurance minefields. Thank you so much for joining us this evening, Dr. Getson. Welcome.
And thank you for inviting me to be the first speaker in the Thermographic Diagnostic Imaging Health Through Awareness webinar series. I'm excited about the prospect of being able to talk to so many people through the internet and via the webinar. I hope that the information that I impart this evening will be beneficial to all those listening. I want everybody to understand that what they're about to see and hear are the opinions that have been garnered from the medical literature, most of which comes from the recent past. They are statistics that I'm sure some will find extremely interesting and others will find mystifying. The purpose of this evening's webinar is to give everybody a broader based knowledge of breast screening and to talk a little bit about thermography and a little bit about how the current insurance system works, so that when it comes time to make decisions about moving forward, following your breast screening, you're a little better equipped to do so. So as the first slide says, we're going to talk about the good, the bad, and the ugly. And the good, of course, will be thermography. Thermography will be discussed a little bit later in the webinar extensively. The bad, mammography. And the ugly.
And I guess any woman who's ever had a mammogram can certainly relate to that image there, Dr. Getson.
Okay. Did we know as clinicians that the compression of a breast, which we currently equate with mammography, was a problem? Well, there's literature that shows that in 1928, which is about 40 years before the first mammographic equipment, Dr. D.T. Quigley wrote in Radiology, which is a journal for radiologists who are doctors that interpret x-rays, warning physicians to handle cancerous breasts with care for fear of accidentally disseminating cells and spreading cancer. So this is not a new concept. The concept of breast compression being problematic goes back about 40 years. Moving forward to the 21st century, in 2005, the National Toxicology Program classified X-radiation as a human carcinogen. And it classified as some of the X-radiation devices, X-rays, CAT scans, fluoroscopy, mammography, and other medical radiologic procedures. It further went on to explain that these forms of radiation have the ability to break chemical bonds in molecules, including DNA molecules, disturbing normal function and making those DNA molecules more susceptible to cancer and other diseases. So in 2005, a national program made the determination that mammography was a carcinogen. In 2009, on the front page of the New York Times, on Fox News, CNN, and all the major news outlets, a story was released on November 16th, stating that the U.S. Preventative Task Force for Breast Screening recommended to the general public that they change their long-standing position on mammography. The comments made in that article were listed there and says, and the quote, "Rather than benefiting from screening, women with cancer may incur harm when undergoing mammography, additional imaging, and biopsies." Now, this caused, as you can well imagine, quite an uproar. It caused an uproar in the medical community because this was really flying in the face of a long-standing position that was 40 years in the making. The gynecologists, the radiologists all scampered around to say, well, you know, it's not this, it's not that, it's not the next thing. But this was a panel commissioned by the United States government specifically to look at breast screening throughout the country, to look at statistics and come up with a recommendation. And the recommendation that they made was that, at least based upon their study, mammography may cause more harm than the benefits that it brought forth. Moving forward 2 years, the British Medical Journal, one of the most prestigious journals in the UK, confirmed that breast cancer screening, and they were talking about mammograms, may cause women harm, especially during the early years after they start screening. And they talked about surgeries, lumpectomies, mastectomies, and other often unnecessary interventions. Now, I have the words often unnecessary in parentheses, which is the way that the article was written, but you're going to see over the next few moments that the terms often unnecessary or unnecessary are going to recur repeatedly. The Nordic Cochrane Center refers to a group of individuals in the country of Norway. The Cochrane Center is the name of the facility. And as a general rule, what they do is they study outcomes. What I mean by that is they take statistical data from studies that are done in various medical applications all over the world, and they correlate data. They are mostly statisticians. And their purpose is to take this data and release a report for the general public, and they rarely make recommendations or comments other than to offer conclusions based upon the data that they have accumulated. So they did a report that was released in 2011, reiterated in 2013. And they stated if 2,000 women are screened regularly, they were talking about mammography here, if 2,000 women are screened regularly for 10 years, so we're now talking about 20,000 mammograms, 2,000 women, one, capitalized underline, one woman would benefit from the screening as she will avoid dying from breast cancer. They further went on to say at the same time, 10 healthy women will become cancer patients and will be treated unnecessarily. So there's that word again. These women will either have a part of their breast or the whole breast removed, and they will often receive radiotherapy, X-ray, radiation therapy, and sometimes chemotherapy. So the staggering statistic on this slide is that the number of women who would benefit from mammography based upon their statistical analysis was 1 in 2,000. Further, they stated that about 200 healthy women would experience a false alarm. And they commented that the psychological strain, until one knows whether or not it was cancer and even afterward, can be severe. This is a facet, This is a facet of diagnostic testing and screening that is often overlooked. So their conclusion, which was a little unusual for them to draw a conclusion, was it therefore no longer seems reasonable to attend for breast cancer screening. In fact, by avoiding going to screening, a woman will lower her risk of getting a breast cancer diagnosis. In 2011, Dr. Susan Love, who was nationally renowned as a breast surgeon at UCLA in California, stated that at least 30% of tumors found on mammograms would go away if you did absolutely nothing. So this comment from an MD breast surgeon in California again created further thought and further uproar and made everyone in the medical community that studies breast cancer outcomes and breast disease screening ask the question, if she's accurate in saying 30% of tumors would go away if you did absolutely nothing, if the Cochrane group said 1 in 2,000 would benefit from screening, it's time perhaps to rethink what we're talking about when we're doing screening mammograms.
Dr. Getson, may I ask a question regarding that previous slide? And it's gone now, so I may get it wrong, but okay. They said at least 30% of tumors found on mammograms would go away if you did absolutely nothing. Are they saying that the 30% of tumors found are not actually cancerous, or there are cancers that a woman could live with for the rest of her life? Do you have any further explanation?
I think her comment was based upon the fact that 30% of tumors found on mammograms are so small and innocuous that if you did not treat them and made adjustments in your healthy living program and diet and lifestyle modifications, you might very well be able to get those tumors to reverse and go away simply by improving your overall health.
Okay, thank you.
In November of 2013, just a year and a half ago, two MD gynecologists, Archie Blyer and Gilbert Welsh, concluded a study that was 32 years in the making. And they said that screening mammography accounted for an increase in breast cancer diagnosis in 122 cases per 100,000 women. But more importantly, of those 122 cases, only 8 of them were felt to have progressed to late-stage breast cancer. Further, they estimated that breast cancer was overdiagnosed, and their description of overdiagnosis was tumors that were detected on screening that would have never led to clinical symptoms. In 1.3 million women in the last 30 years, and in the year 2008 alone, which was the last year of the study, they estimated that more than 70,000 women were overdiagnosed, which was 31% of all diagnosed breast cancers. Dr.
So is this saying then, they're saying that they're finding cancer sooner, the mammograms are finding more cancer, saving more lives, their numbers are going up, but looks to me like the numbers may be skewed if it's being overdiagnosed.
That's exactly right. Dr. Wells concluded that few breast cancers are destined to kill no matter what we do. So this is a reaffirmation of what Dr. Love said a couple of slides ago. It's a reaffirmation of the Nordic Cochrane study that said only 1 woman out of 2,000 would die from breast cancer. And they studied breast cancer outcomes for 32 years in this country. So this is not, sometimes we hear, well, the study had 22 patients or 35 patients. This is a study that went on for 32 years.
That fear factor is tremendous when it comes to breast cancer. And
yes,
really drives the breast cancer industry, or drives women to get caught up in that cancer vortex.
You're correct, and I think part of what we're trying to accomplish this evening is to make these statistics, which are readily available, but not highly publicized, available, so that any woman who is unfortunate enough to be told that she has a breast cancer diagnosis is better equipped with statistical data to make informed decisions about what she's going to do with that.
And maybe instead of jumping right into the biopsies and radiation and chemo, maybe take a step back, get a second opinion, do a little searching and get some answers.
I agree completely. Very, very rarely is a breast cancer something that you have to run out and do something tomorrow with.
I think that's very important for women to know.
It's interesting temporally, because last night I was talking to a woman in a phone conference who was diagnosed with DCIS, which we'll talk about in a moment, and a stage 2 ductal carcinoma. And she said to me, I don't think that they're moving fast enough with their workup to try and diagnose, they're not doing the scans fast enough, they're not doing the workup. And I said to her, there's no rush. I mean, this is not something that has to be done tomorrow. Take your time, do your due diligence. Hopefully she's a part of this webinar this evening, and understand what these doctors who have studied this extensively are saying, which is that very few breast cancers are destined to kill. Very few breast cancers move on to late stages. And there's really no rush. Take your time, look at all the facts, and make an informed, intelligent decision. Moving forward again, the British Medical Journal, just a year ago, published an article that memorialized a study that was done in Canada. And it was done by the Canadian National Breast Screening Study, which is a 25-year follow-up on breast cancer incidence and mortality. So again, like the study that we just talked about from Dr. Welsh and Dr. Blyer, this is an extensive study. And the conclusion of the study was that annual mammography in women ages 40 to 59 does not reduce mortality from breast cancer beyond that of physical examination or usual care. They further said that overall 22% of screen-detected invasive breast cancers were overdiagnosed, which is one overdiagnosed breast cancer for every 424 women who underwent a mammogram. And the conclusion was that assuming that nearly all overdiagnosed breast cancers in the study were non-palpable, meaning that they were not being able to be felt by a clinician doing a breast exam or an individual doing a self-breast exam, 50% of mammogram-detected non-palpable cancers were overdiagnosed. So the recurrent theme over these few slides are often unnecessary and overdiagnosed. Many women who are listening to this webinar this evening have been told that they have dense breasts, especially in the younger age groups. Breast density, to the point of being problematic for the interpreter of a mammogram, runs to be about 50% of women. So Bonnie Rush, who was the president of breast imaging specialists at a radiologic seminar in 2014, said trying to find a breast cancer in a dense breast via a mammogram is like trying to find a snowball in a snowstorm. Now, her statistics were that the estimated sensitivity of a mammogram is 80 to 85% in a woman who does not have dense breasts, and 62 to 68% in women who do. And that's 50% of all women. What makes this particularly frightening is that if there's 100 women in a room, all of whom go and have a mammogram, and all of whom have dense breasts, and all of whom have reportedly normal mammograms, somewhere between 32 and 38 of those women are actually walking around with a breast cancer diagnosis that was missed on a mammogram. And the American College of Radiology said that women with greater than 50% breast density makes it extremely difficult to see anything, hence the term snowball in a snowstorm. What I find interesting is the American College of Radiology knew this 22 years ago. And at that point in time, they basically knew that breast density was a problem for the interpreters of mammograms or radiologists, and it was not publicized in 2000 until the 21st century. So what happened was some of our senators and congressmen introduced a bill in July of last year saying that it should be federally mandated for a minimum standard to be established for women to notify them that they have dense breasts. Therefore, saying to them that because you have dense breasts, it decreases the accuracy of the interpretation of the mammogram. At present, 21 states, including New Jersey, have enacted that law. And what you get is you get your report, and then you get the disclaimer that is written in the box that you see. Your mammogram may show that you have dense breast tissue as determined by the breast imaging and reporting and data system established by the American Academy of Radiology. Dense breast tissue is very common. You just heard me say it's about 50% and not abnormal. However, in some cases, 32 to 38%, dense breast tissue can make it harder to find a cancer on a mammogram and may also be associated with a risk factor for breast cancer. Now again, in terms of time, this disclaimer comes to you with your report after you have undergone the compression and radiation inherent in a mammogram.
Well, was that part of the bill? Were they supposed to give women this information prior to having the mammogram?
Ideally, I think it would be, we've done a couple of images, you have dense breasts, you need to understand that the accuracy of this is decreased. Do you want to continue or not? But they don't. They finish the study. Sometimes they bring women back for additional views. And at that point in time, they report that the study is normal, or whatever the report is, but oh yeah, by the way, you have dense breasts.
Isn't it true, Dr. Getson, that women's breasts are really too dense until the age of 50? And some women still say that they have dense breasts into their 60s.
That's completely accurate. And in fact, when I talked about the New York Times article, one of the recommendations that was made in that article is that screening mammogram, which was conventionally supposed to be done at the age of 40, according to that recommendation, was pushed forward to 50 as the first year in which screening mammograms should be done, exactly for that reason, because of breast density in younger women. And you are absolutely correct. Women in their 60s sometimes have dense breasts. And by then, if they're in their 60s now, they probably had 20 plus years of mammograms.
Yeah.
A couple of comments from some people. Dr. Simone was assistant clinical professor of immunology and pharmacology at the National Cancer Institute. And he said mammograms increase the risk for developing breast cancer and raise the risk of spreading or metastasizing an existing growth, which you saw in the very first slide from Dr. Quigley in 1928. Dr. Simone also said, since mammographic screening was introduced in 1983, the incidence of DCIS, ductal carcinoma in situ, which in his comment represented 12% of all breast cancers, and we'll talk about that in a minute, has increased by 328%. 200% of this due to the use of mammography. So he is attributing a 200% rise in DCIS diagnosis to the carcinogen that is known as mammography. And he said the increase from women under the age of 40 went up by 3,000%. That is not a typographical error.
That's an incredible statistic.
It is, and taking it forward, let's talk about DCIS. In July of 2013, a working group from the National Cancer Institute, and I think it's interesting that some of these articles are coming from gynecologists, breast surgeons, and the National Cancer Institute, because a lot of naysayers say, well, this was written by somebody who's anti-mammography or this. These are people that are involved in the day-to-day evaluation and assessment of breast cancer. So in JAMA, the Journal of the American Medical Association said DCIS should be renamed to exclude the word carcinoma because it would cause less fear in patients. And they recommended calling it indolent lesion of epithelial origin, which is IDLE. And basically they said, it's not cancer. Dr. Otis Broley, who's the chief medical officer for the American Cancer Society, said we need a 21st century definition of cancer instead of a 19th century definition, which is what we've been using. And Dr. Esserman, who is the director of the Carol Frank Buck Breast Cancer Center at University of California, San Francisco, and is a professor of surgery and radiology, so she's got it from both sides, okay, said DCIS is not cancer, so why do we call it cancer? And yet, there isn't a week that passes by that we don't hear tell of a woman who's been diagnosed with DCIS and has a mastectomy, and some bilaterally.
That kind of goes, well, the slide before this, where that incredible 328%, again, this increase of numbers of cancers being diagnosed, but they're diagnosing something that is not even cancer. That's what you're saying. And so they're increasing the mammograms, which may be causing the DCIS, which isn't cancer. It's what you're saying, right?
That is correct, and there are just scores of women who are being told that DCIS is breast cancer, that they need radiation, they need chemotherapy, they need surgery. And based upon this slide and this statistic from the National Cancer Institute and experts in the field, that's simply not true.
Okay. Is there something a woman can do for DCIS?
I'm sorry, can you repeat that?
Is there something that a woman could do for DCIS?
Yes, what a woman should do for DCIS is watch it and get involved in diet and lifestyle alterations, which we'll be discussing in a few minutes. But based upon the statistics that have been presented through the National Cancer Institute, there really is no intervention necessary for a DCIS diagnosis.
Okay.
So one of the things that we're told is that a mammogram is an early detection means of breast cancer. And we know statistically that by the time a tumor has grown to a sufficient size to be seen by a mammogram, it's been growing for 7 to 10 years and has achieved more than 40 doublings of the malignant cell colony. Now, this is a chart that talks about how cancer cells grow. Please understand that everyone who is listening to this tonight and will listen to this in the future has cancer cells in their body. Most of our bodies are equipped with an immune system that allows us to fend off the cancer cells, and hence we don't get a diagnosis of cancer. When the immune system is compromised, what happens is the cancer cells begin to become stronger than the immune system can fight. And so the cancer cells grow exponentially, and you see that what at 90 days is 2 cells, at 7 years is 268 million. And I've highlighted that 7-year number for a reason that will become evident shortly. I want to go back one side, and it says that the tumor has been growing for 7 to 10 years and has achieved more than 40 doublings of the malignant cell colony. So at 7 years, which is the hallmark of this slide, there were 268 million cells. The point being, and what we're going to get to is, okay, wouldn't it be great if you knew there was something wrong with the breast when that number was 256 or 896? Because after all, we are looking at a diagnostic test, as we're talking about mammography, that is looking for a tumor so that someone can tell you what to do to get rid of the tumor. It is not a test that is screening the breast and saying, there are changes that are problematic, you need to do something now, because if you don't do something now, there's a high probability that you're going to get cancer. Another topic is 3D mammograms or tomosynthesis. Back to radiology. In Radiology Today in 2011, they said because the digital breast tomosynthesis exam requires at least 2 additional exposures over a standard mammogram, the total radiation dose from the combined 2D and tomosynthesis examination is 3 times that of a standard mammogram. So if it wasn't bad enough that you're getting carcinogenic radiation from a mammogram, now we're talking about having 3D mammograms, which have 3 times the amount of radiation. And finally, in April of last year, the Medical Board of Switzerland, we are now talking about the Medical Board of the country of Switzerland, recommended to the Swiss government that no more mammographic centers be allowed to open in the country, and suggested in April of 2014 that all mammographic centers in the country be closed and that no further mammograms be done. And the reasoning behind this was that they had studied mammograms and outcomes. They had looked at the data, some of which you have seen this evening, and they concluded that the reason that they were doing mammograms was based upon data from the 1980s. It was 25 to 30 years old. And when they looked at the more up-to-date data and the more up-to-date statistics, they realized that the harm that was being done from mammographic examinations far outweighed the benefit of doing a mammogram. And so the recommendation from the medical board of the country of Switzerland to the government was no more new centers, and let's shut down the ones we have.
Do you think that that will impact any other countries or the United States as far as our views?
I don't know if it'll impact the United States in the immediate future, but I can tell you that in many countries of the world, Brazil, Germany, Poland, Switzerland, Switzerland, of course, Japan, they're really taking a hard look at mammography because of these statistics that have been forthcoming here in the 21st century. And while nothing else has been stated in the medical literature about this happening in any other country, there's clear-cut evidence that people are looking more closely at the entire diagnostic testing system and screening system for breast disease.
I believe in Europe, Italy, France, their views on mammograms are perhaps a mammogram every 5 years, and they're very strong proponents of self-breast exams.
That's correct. And Germany in that list as well is especially reticent to suggest that people should have mammograms, and when they do, it is done at spaced out intervals as you just suggested.
Maybe if there's a concern, if a woman has a physical exam by her clinician and there's a concern, they may do a mammogram at that time.
Generally as an adjunct to abnormal clinical findings or other diagnostic tests, that is correct.
Okay.
So my conclusion is that it is an indisputable fact that a man invented mammographic equipment. How did I come to this conclusion? Because if a woman had invented the apparatus, she would have created this.
Yeah.
When I give a lecture and there's a man sitting in the audience, the look on his face is priceless. So we've talked enough about mammography at this point in time. Let's talk about other tests. And let's go back to what I said at the beginning. We talked about the good, and now we'll talk about thermography. Some of you listening have undergone thermograms, others are contemplating it, and let's talk a little bit about a non-invasive early detection breast health risk assessment tool. And what makes this different from a mammogram is that we're now taking heat pictures, because the word thermogram actually comes from the Greek, which means exactly that. It is a heat picture. It is a picture that measures the heat that emanates from the skin surface via infrared cameras, which of course emit no radiation. And the apparatus that we use looks like this. The camera is on your left, the laptop screen is there on your right, and it's just that simple. So what is thermography? Thermography uses state-of-the-art FDA-approved infrared technology to provide an image of the body's physiologic responses. Now at this moment, I want to differentiate between physiologic and anatomic. Mammograms, ultrasounds, and MRIs are anatomic tests. Anatomic tests are tests that look at the anatomy, meaning they look for cysts and tumors and other identifiable objects that can be seen as existing. Physiology looks for the activity of the body. How is the body working? How is the body functioning? And most frequently, I use the following example. A woman walks into my office with 104 fever. She's coughing, she's wheezing, she can't catch her breath, and she's sick. I listen to her chest. Her chest is rumbling and rattling and wheezing, and I say to her, "You have pneumonia. You need to go get an x-ray." And she walks across the parking lot to the hospital, and she gets an x-ray, and I get a phone call from the radiologist who says the x-ray is normal. How's that possible? This woman has a fever, a cough, and physical findings. It's possible because the anatomic test, which is the x-ray, lags behind the physiologic findings, which is what I'm hearing with my ears and what she's feeling. 2 or 3 days later, that x-ray will show the pneumonia. And 3 or 4 days after the pneumonia is clinically gone, you're still seeing the residue of that improving pneumonia. So the difference between anatomy and physiology is that physiology comes first. How much first? Well, in breast disease, as much as 7 to 10 years. And now you understand why I showed you that slide with 200+ million cells as the 7-year hallmark. Because if we knew 7 years before the formation of a breast cancer that the breast was malfunctioning physiologically, it would give us the opportunity to intervene and perhaps do something to minimize or even prevent that cancer from coming. Thermography is totally safe, non-radiologic, non-painless, with absolutely no adverse effects and no contraindication. It can be used at any age. It is not affected by breast density. It is not affected by breast surgery. It is not affected by any factor whatsoever. And it is perfectly safe. And it detects the physiologic responses in the breast that have been shown to correlate with cancer or precancerous states. Physiologic changes. And because it does this at the cellular level, studies have been shown to suggest that thermography can detect activity in the breast 8 to 10 years before other testing. Thermography is very sensitive, up to 90%, and when used as part of a comprehensive, multifaceted approach with physical examination and anatomic testing, it will lead to early detection of 95% of early-stage cancers, which increases long-term survival rate by as much as 60%. Some people will tell us, I never heard of this, it must be new. Well, the first recorded thermobiological diagnosis in front of the government of the United States was in 1972, when the Department of Health, Education, and Welfare recognized thermography as a diagnostic test for pathology of the female breast. In 1982, the Bureau of Medical Devices, Food and Drug Administration, Health and Human Services, which is what's now metamorphosized itself into Medicare, said thermography can be useful adjunct for diagnosis in many areas, including musculoskeletal injuries. So in 1972 and again in 1982, the government of the United States in its various incarnations said it works. What makes this interesting is that thermography predates mammography by at least a decade. So the proper protocol for imaging, according to the guidelines from the American Academy of Thermology, which were written about a year and a half ago, revised a year and a half ago, was that the room be 68 to 71 degrees, that the patient disrobe to the body to equilibrate, or to get his or her body to that room temperature of 68 to 71 degrees, which is almost always 68 or 69 degrees, that there be no light coming into the room that would disturb the test, that the air vents be deflected so they were not blowing on the patient, and that we do a cold test to capture sympathetic reaction so that we can see whether or not some changes that occur in the breast thermogram are the result of a sympathetic response or the result of something that is physiologically abnormal. Who should have a thermogram? Well, patients at high risk from family history, patients with breast implants, dense breasts, which we talked about extensively, patients with surgical scars, inconclusive anatomic studies. Well, the mammogram said this and the ultrasound said that, and I'm not really sure what to make out of it. Patients with conditions making breast compression impossible, conditions such as reflex sympathetic dystrophy or compression, conditions where compression would be so painful that it really is contraindicated. And my favorite, which is why it's bolded and underlined, patients wishing to avoid radiation and compression of the breast, which pretty much includes every woman I've ever met. In the American Journal of Radiology, and remember, this is again, I'm reiterating, these are people that read x-rays. They're saying thermography could help prevent most unnecessary breast biopsies. Here's that word again, unnecessary. Infrared imaging offers a safe, non-invasive procedure that would be valuable as an adjunct to mammography in determining whether a lesion is benign or malignant. Now, this study in 2003, which talked about an adjunct, came about 10 years before the studies that I've shown you that extensively and exhaustively concluded that mammograms perhaps are not all that they were cut out to be. That same study said that the warming patterns seen in thermography have been found to resolve and return to normal after a few short months of healthy diet and lifestyle changes. Therefore, thermography is the first tool we have that shows the promise of being able to pick up breast cancers at so early a stage that involves only precancerous physiologic changes, that women can reverse these changes and avoid getting breast cancer by making a few simple diet and lifestyle modifications. So earlier we talked about what can you do if you get a DCIS diagnosis, and the answer lies in these underlined words: modification of diet and lifestyle. Couple of testimonials. Dr. Christine Northrup, who most of you probably know as a huge proponent of women's health, who actually had a book that came out this week on women's health, and who is a huge proponent of thermography. She says thermography is a breast health screening modality that actually helps prevent breast cancer and not just diagnose it early. I highly recommend this approach. If you've ever heard Dr. Northrup talk, she will tell you that she's never had a mammogram and that she has always used thermography as her breast health screening tool. And as a little aside note, in 2013, she was the keynote speaker at a conference, and her speech was about what women want. And a few minutes into the speech, she stood up and said exactly that she's never had a mammogram, and that she was an advocate of thermography, and was kind enough to point out that I was sitting on the front row of that lecture, and referred to me as the thermographer, and touted the benefits of thermography. That is Dr. Northrup, and us at that conference. Dr. Mercola, who I'm sure all of you know, said thermographic breast screening is brilliantly simple. Dr. Mercola for a time actually did thermography in his office and continues to tout the benefits of thermography, and in many of his papers, the downside of mammography. Dr. Mercola's center is in Chicago, where we visited and had the opportunity to see what he did on a first-hand basis. So we're going to talk about thermograms a little bit, and I'm going to show you a few examples of thermograms. The picture on the left is obviously a color images of thermogram in black and white. We take both color and black and white images. The black and white images allow us to identify the blood vessels much better, and the color allows us to determine temperature differentials. We operate under the premise that the human body is symmetrical left against right within a certain parameter. That parameter is 1 degree at the nipples and 1.5 degree elsewhere in the breast. So we don't expect women to be exact mirror images of themselves. We recognize that there is a disparity in temperature, size, shape, etc. So we allow up to 1.5 degrees centigrade, and that's some of the numbers that you see below. The picture on the right represents a woman that had a mass, and the mass is to the far left of that picture, which is in her right breast, and it almost looks like a baseball diamond there. You see it circled with a black circle above it, and on the left-hand picture you can see it circled with a black circle to the far left of that image, which again is in the right breast. And this is a woman that palpated a mass, that came in to see us, that had all the criteria for worry, a closed pattern, which is the black and white diagram, with elevated heat, which is the color diagram. She went ahead and did her due diligence and had an ultrasound and had a mammogram, both of which were normal, and decided based upon the thermogram to go ahead and have a biopsy, which at that point in time demonstrated a breast cancer. This is a woman who had a huge family history of breast cancer, which 10 years ago was thought to be a major component of cancer genetics, and recent studies have suggested that the genetic component of cancer is about 4%, which I'm sure will astonish many of you. But this woman, because of the huge family history, had 9 years of normal mammograms, 5 years of normal ultrasounds, and 3 years of normal MRIs, and on a self-breast examination found her own breast lump, which correlated with the picture on the left, suggesting that she had physiologic abnormalities that were suspicious, talked her doctor into a biopsy, which showed cancer. She subsequently underwent a mastectomy, had follow-up treatment to that, and now, I think about 10 years later, is really quite well and doing fabulously. So you heard me mention diet and lifestyle changes, and one of the things that we tell people in lifestyle changes is to rid themselves of underwire bras. And the reasons are twofold. One, because the metal in underwire bras conducts electromagnetic waves, but more importantly, that metal compresses the lymphatic system, which certainly is not something that you want to do. You want free-flowing to minimize the likelihood of passive lymph congestion, which is more likely to be, the stagnation is more likely to lead to disease such as breast cancer. And so when you look at this, you see that after 13 months, the top two pictures show you the asymmetry in the women. How the left breast has all that vibrant blue and the right breast has all of this greens and on, and the circles would show you temperature differentials. And if you look at the top right picture, way over to the right side, you see a little circle with a yellow dot in it, which was a worrisome spot for me. And when you look at the bottom picture, you see that the breasts almost look like a mirror image, like somebody just put a mirror in the center. And the only change this woman made in her breast health was to discontinue the underwire bras. This is a woman who, the top pictures are her normal eating habits, and the bottom was after she went gluten-free. If you look at the top picture, you see the great disparity in temperatures on the right side between the breasts, and when you look at the bottom, you see that while they're not completely perfect and symmetrical, they're vastly better than they were. And if you look at the circulation on the top left picture, you see that it's almost the same pre and post gluten, because blood vessels will never go away once they come. But the activity of those blood vessels is what changes. So her discontinuation of the gluten improved her breast health immeasurably in a 4-month time frame. This is a lady who eliminated caffeine, sugar, and red meat. And if you look at the left-hand picture, you see the difference between the two breasts. And when you again look at the right-hand picture, you see the virtual symmetry of the breast. These are simple diet and lifestyle alterations. And this last picture is astounding. This is, let me assure you, this is the same woman, because I've had people say this is two different women, and it is not. The top two pictures are before, the bottom two pictures after. This woman lost 50 pounds, changed her diet, and began a daily exercise regimen. The top two pictures show you changes in the color where there's a disparity, and look at the blood vessel patterns in the black and white. And look at how intense those patterns of blood vessels are, and how severe and dark they are. And on the bottom picture, you see that while the blood vessels are still there, they've begun to fade out a little bit. They're much less intense, and she's got 2 less chins than she had on the top picture. This is exactly the same woman who just decided she was not going to let things get her down, and she implemented a program and really put her mind to major change in diet and lifestyle. So quickly, a couple of other things. We do thermography for neuromuscular reasons and what we call thyroid facial dental studies. For neuromuscular, we're looking for sympathetic dysfunction. It is my estimation, and you heard when Leisha said one of the things that I do is I talk about reflex sympathetic dystrophy. It is my estimation this is the best diagnostic tool for reflex sympathetic dystrophy. This is a patient with RSD of the left leg. We look for dental issues because the camera is sensitive and it will pick up dental issues such as those that you see on the screen. The dental issues we have found in hindsight and in the dialogue we've had with patients are almost always in a place where someone had a root canal or intervention done. We look at thyroid problems, which is what you see in the very center of this picture, because thyroid blood testing is notoriously inadequate. Many people have thyroid dysfunction and are clinically hypothyroid, but the blood tests are normal, and it puts us physicians in a bad place. How can I treat something if the numbers are normal? And what we have found is that there is a direct correlation between thyroid and dental issues, and in some cases there is a direct correlation between thyroid and dental and breast cancer. In one particular case, we were able to draw a direct line down from a failed root canal, an increased dental heat thermogram, directly down to the site of the breast cancer in that particular individual. So I had said earlier we were going to talk about some other tests. Ultrasound uses sound waves which bounce off the breast to create a black and white image. Ultrasounds are very good for determining whether something is cystic or solid. Obviously, cystic lesions are absolutely nothing to worry about. Cystic breasts are very common. Ultrasound is covered by most insurances. It's relatively inexpensive. Its deficiency lies in the fact that if you're looking at large areas of the breast, it's not particularly good to determine that. And an MRI or a magnetic resonance image uses magnets to pull apart the body's water molecules. There is no radiation. In breast studies, this is done following an intravenous injection of gadolinium, which is a water-soluble dye. Now, one of the problems with MRIs is they're quite expensive, and getting the insurance company to pay for them is really a problem. I will tell you that Horizon Blue Cross and Blue Shield of New Jersey has a policy that they will not pay for a breast MRI, regardless of situations. A PET scan is really a study that looks for spread of tumors once cancer is diagnosed, and I put this in here for this reason. We talk about diet and lifestyle alterations. The way that they do a PET scan is they inject a tracer or a dye, and the dye will go to the areas where cancer exists. And that says, okay, there's cancer where we know it is, but it's also here, there, whatever in the rest of the breast. What makes this interesting is that tracer, that dye, is predominantly sugar, which reinforces the theory that sugar feeds cancer. Back to diet and lifestyle alteration. So a couple of quick insurance issues, and then we'll take questions.
Dr. Getson, could we just back up a little bit about the ultrasound and talk about the protocol that we use at Thermographic Diagnostic Imaging when we need testing of an anatomic nature?
Certainly, I'll do that. If I see a thermogram that's abnormal, and the abnormality is in a relatively small area, as we saw on that first slide where the woman had that diamond-shaped lesion on the outside of the breast, I will recommend to women who want a recommendation that we go ahead and we do an ultrasound. And the reason is because the thermogram pretty much gives the radiologist a roadmap of where we're looking. I'm able to say it's in the upper outer portion of the breast or the lower inner portion of the breast. And so we're able to focus those sound waves, and we're able to hone in on a site. We're able to look at that. If the breast is universally hot and there's a lot of blood vessels and a lot of worrisome areas, it's probably not as good a diagnostic test for that. And then we look at MRIs. MRIs are really a very good diagnostic test. There is no radiation, there is no compression. Yes, there is the injection of gadolinium, which is a water-soluble dye. It's excreted in the urine in the same day. There are reports in the literature of some women having a reaction to the gadolinium, but it's about 1 or 2%, so it's a very, very small. I've never seen a reaction to gadolinium personally, and so we will try and help women lobby for getting an MRI, which is a highly sophisticated study that looks at the breast from an anatomic position, but it does it without radiation or the compression of the breast.
So can you just address the fact that when women go for an ultrasound, they are coerced or forced into having a mammogram?
That's correct, and which I'm going to take you to right here. The radiology community has established a rule that says you can't have an ultrasound without a mammogram. This is nonsense. There is no law. There is no rule. There is absolutely nothing in the medical literature, the insurance literature that I have ever seen. This is an attempt to coerce women into having mammograms. And we have talked to these centers, and I asked them to cite studies and literature, and there is none. And so more and more centers are now saying, we're going to tell the women that it is our recommendation that they have a mammogram, but if a woman exercises free choice and says, I'm not going to do that, they're going ahead and doing the ultrasound without the mammogram.
And we do have a couple of sites that we work with in southern New Jersey that will do an ultrasound without coercing the women or trying to force them to have a mammogram.
Correct. MRIs are costly. A breast study can be anywhere from $800 to $2,000. Interestingly, if you pay cash, you can get one on sale. I mean, there are actually discounts for cash patients. It requires a pre-authorization, and Horizon Blue Cross and Blue Shield will not authorize it. And this statement, which I still find incredible to this day, but this is what they told me directly, was that they will not authorize an MRI for a breast unless you already had a diagnosis of breast cancer based upon a biopsy. And I said, when I went to medical school, you do diagnostic testing to avoid breast biopsies. I don't get it, and that's just simply their policy, and they're unwavering in it. Medicare will pay for MRIs with just cause. Some of the just cause includes prior MRIs, and this is a repeat prior diagnosis of breast cancer, inconclusive but suspicious studies, the much publicized BI-RAD gene positivity, and as I talked about earlier, in patients who can't have compression of the breast, such as reflex sympathetic dystrophy, Medicare will pay for a breast MRI in those cases. And sometimes there's a fight, but the fight is something that you have to be willing to do, and we are willing to do, to help people get the right diagnostic test in the right circumstance. And so here's just a brief listing of diet and lifestyle modifications. This is by no means meant to be comprehensive and all-inclusive. It talks about organic foods when you can, gluten-free, which we think is extremely important, eliminating processed foods, white sugar, white flour, and white salt, which is the first step for everybody. And some things that don't have to do with eating, like commercial household cleaning products and garden pesticides. Synthetic hormone treatments, detoxification, emotional things, positive outlooks, adopting an attitude of gratitude, stress release mechanism. We all have stress, so things like meditation or yoga, or something as simple as just going into a room, turning off the computer, taking your cell phone and putting it in another room and sitting down and reading a book or a Kindle or something that makes you relax mentally, physically, and emotionally for a period of time. Try to maintain relationships that are healthy, explore whatever spirituality you have, and supplement your diet with appropriate vitamins and nutritional support to the degree that your diet does not include that, because most of the nutritional support and vitamins should come from a healthy diet. So I understand we have some questions, and if you'll read them to me, I'll be more than happy to help you if I can, and let you explain the last slide, Leisha.
Okay. So, folks, we are at about 5 of 7, but we'll be happy to stay on and answer the questions that we have. The first question: does BHRT contribute to breast density? This is a question from Josie.
Does the HRT? I'm sorry.
She has written BHRT, contribute to breast density.
Okay, so we're talking about hormone replacement therapy, and the question really is one that is of great debate. In individuals who do hormone replacement therapy, and I don't, and so I will make the disclaimer that I am by no means an expert. There are some who believe that hormone replacement therapy is a really good thing. Others who believe that hormone replacement therapy is a really bad thing, and I think the jury is probably pretty much out. I suggest that everyone who is considering hormone replacement therapy do what we're advocating tonight, which is do your due diligence, get on the internet, look it up, look at the most recent studies that have been done, and see if it appears right for them. The other disclaimer that I want to put in here, which is really very important, is that if you're going to do hormone replacement therapy, I think it is essential that you periodically assess the levels of estrogen, progesterone, and other hormones in your body. You just don't get on a hormone replacement program and assume that it's the proper one and just stay on it. There are really good ways to assess hormones. Saliva is the best way. Blood tests are a little inadequate in my estimation. But you really should assess the hormone balance, because just going on hormone therapy, it's not one size fits all. And so if you're going to take that therapy, make sure that there's a balance, because we do know statistically that many breast cancers are estrogen-dominant cancers. And so if you go on hormone replacement therapy and you wind up with an imbalance of estrogen and progesterone, which means too much estrogen and or too little progesterone, then that will increase the likelihood of breast cancer statistically. So not so much from the hormone per se, but from what it's doing to the body's estrogen-progesterone balance.
So then it would contribute to breast density?
Not to breast density, but to breast cancer possibilities. Now, hormone replacement therapy will not, in my estimation, contribute to breast density.
Okay, thank you. The next question. If a thermography shows an abnormality, should a mammography be the follow-up? If not, what is recommended? And I think you'd answered that, but go ahead. This is from Joanne. Okay,
well, the second most popular question that I get is, now that my thermogram is normal, and I'll take it from this perspective, now that my thermogram is normal, do I still need a mammogram? And my answer is always the same. I have a medical license in this state that I would like to keep. So it's not my place to say don't have a mammogram. That's a very individual decision, and it's a decision that each woman should make based upon their own due diligence, their own assessment of the risks and benefits, their own assessment of the statistics that are available to them, and their own instinct and gut feeling. What I can tell them statistically is that a normal thermogram is the best indicator of a normal breast. Now, it doesn't mean that there's not some that some fall through the cracks. I'm not going to say it's perfect. But what I tell people is that if you have a normal thermogram, the likelihood of having breast cancer is very, very small. Not none, but very small. But that's a very individualized decision. And in answer to the second one, we already talked about ultrasounds and MRIs.
So at TDI, if there's an abnormal thermogram, you recommend a clinical exam or an exam by the clinician and either an ultrasound or an MRI.
That's correct, and breast self-examination, which I think is very, very important.
Okay. The next question from Karen. What can we do to help get this important information to insurance companies so that this valuable screening can be covered?
That's a really difficult question to answer. It's something that I've been wrestling with for over 30 years. I think that the best way to impart the information is for women to be proactive in their own health concerns, to say, I'm going to have this thermogram, to submit it to their insurance carrier, and to lobby to get reimbursement for the study. You know, currently, about 30% of women who are having thermography done at our facility are getting reimbursed a portion of that fee from the healthcare insurer. If you'd asked me the same question 5 years ago, it probably would have been 5%. So I think the insurance companies are beginning to understand.
And I think that's a direct result of the women. We do provide women with a claim form, and I think that that's a direct result of the women just sending it in and calling the insurance company. That's what's creating the change there.
That's correct. When you send the claim form in, you're going to get an answer. And the answer is either going to be yes or no. If it's yes, fine. If it's no, then pick up the phone and ask them why not. If they tell you it's experimental, you have enough statistics that you've seen tonight to know that it hasn't been experimental since 1972. This webinar is being archived. Print out the slide and send them the citation and stand your ground and tell them, no, it's not experimental. And when enough women begin doing this, enough men begin doing this, sooner or later, the cumulative voice will be heard.
Yes. Okay. Next question. If after breast mastectomy and no lymph nodes involved and no chemo or radiation needed, but aromatase inhibitors strongly suggested, is this necessary, or is there an alternative method available?
It's a question that I really can't answer because it's really a question about the treatment of breast cancer, which is out of my line of expertise, and any advice I would give you would be coming from not enough knowledge. And so I would recommend that in a situation like that, when you're getting that information either from a breast surgeon or an oncologist, that you seek opinions from different specialists. And if your way of thinking is more holistically inclined, then talk to holistically inclined people because they're out there.
Next is a comment from Sherry. Within 3 weeks of Angelina Jolie having double mastectomy in Australia, they had what they called the Angelina effect. Women lined up for double mastectomies. Now, I know that we were cringing when we heard about Angelina Jolie's choice, and it's her choice, and I remember you having a conversation with Dr. Christiane Northrup when this happened. Would you like to comment?
Well, I have two answers. Dr. Northrup had a very interesting spin on this. She said, here's a woman who is taking off both breasts for something that isn't there, and she's doing it ostensibly so that she can be healthy, but injecting toxic dye into her system to get tattoos, which I thought was a very interesting comment from Dr. Northrup. You know, I think that you look at the gene, and the gene says that you are statistically more inclined to get breast cancer than somebody who doesn't have the gene. But it doesn't mean you're going to get breast cancer, and it doesn't mean that if you get breast cancer, it's even going to be a breast cancer that's going to be life-altering. I mean, we saw a statistic tonight that said 1 in 2,000. So if you get a breast cancer, what if it's one of the other 1,999? So I certainly can't sit here and condone somebody having prophylactic mastectomies because they have a gene. It just makes no sense to me.
Yeah. Okay. We'll move on to the next one. Will you be sharing dietary and lifestyle modifications? Yes, we did share that slide, and as Dr. Getson said, the webinar will be archived. I believe you'll be able to print out the PowerPoint. If not, we'd be happy to email that to you. And there's a much more detailed information on the Health Through Awareness website regarding dietary and lifestyle modifications. Another person wanting to share, Kerry, I just have to share, I was diagnosed with stage 0, no lymph nodes involved, DCIS of the right breast in September 2009. I chose to have a bilateral mastectomy with reconstruction in November 2009 out of fear. Today I am partner and executive vice president of De Nova Scan, clinical thermography, and a public speaker, usually sharing my story. Today my mantra is, I wish thermography had been my first line of defense when I received my cancer diagnosis. Now that I know the power of thermography, my passion is to share this with as many people as possible.
Well,
thank you, Terry, for sharing that.
Thank you so very much.
And that's what we need to get the word out, to tell our friends and family, or just do whatever we can to educate.
We by the way, do some speaking engagements at different places, and we're always happy to go out to groups and discuss this with them, because we really feel that this is the best way for education. This is why I'm so delighted to be able to do this tonight and put this out to a large group and make it available to anyone who wants to know. But if there's groups who really want to get this information out, please contact us. We'd be more than happy to go and do this.
Okay. Question from Denise, with regard to dental hotspots in the lower canine area, can this happen if the teeth are shifting sideways? Some alternative health practitioners say if you have a spinal shift, the correlated teeth will shift. That's very interesting.
I want to make sure I understand the question. The question is, can the thermogram be abnormal for dental health because of shift of teeth? Is that the question?
Yes, that's correct.
Well, it's more of a dental question, so I'll approach this from the opposite end. When we see an abnormality in the dental region of a thermogram, my first question, of course, is, did you ever have intervention there? And as I said, I would venture to guess probably 80 or 90% of all women tell me that they did. But my goal at this point is to say, I can give you an area, left lower, more toward the front than the back, and I refer people back to their dental specialist. And if it turns out that is from a shift of teeth, it's not something that I have great knowledge of, but the idea is we're going to identify an area and something, and then turn it back to the individual to go look at that area and make a diagnosis as to what's causing that heat inflammation. So I can't really answer the question any better than that.
Okay. What is the connection between calcifications in the breast and breast cancer?
Statistics show that 85% of all biopsied calcifications are benign. And of the remaining 15%, statistics show that about 13 or 14% of those which are malignant would never progress to late-stage breast cancer. Microcalcifications, which is a buzzword of the 21st century, and you didn't hear it before 2000, is another one of those things that, oh my God, you got microcalcifications, you better do this out of the next thing. And at least in my opinion, okay, it's another fear-based finding. Because when you look at that statistic, It really is a statistic that says 85 and then another 14. So the likelihood of you having a problematic breast cancer is about 1% if you have calcifications. And when people ask me for advice, my advice is the same as with DCIS. You watch it. You do your thermography, you clean up your diet and modify your lifestyle. And a lot of women are surprised, and shouldn't be, as you know from this webinar tonight, okay, that those things start to go away.
Yeah. Okay. From Sherry, how soon after mastectomy and reconstruction can she get a thermography?
A minimum of 6 months, and sometimes even 9, depending. If it's an uncomplicated procedure, a minimum of 6 months to give the surgical area and the inflammation that goes along with the surgery an opportunity to heal. Now, this is assuming that there's no radiation therapy, because obviously radiation heats the breast, and that's going to throw the thermogram off. And by the way, I will mention that there are parameters in place in the thermographic community to look at the remaining breast without the need for symmetry because of the absent breast, and still look at it in a serial fashion to determine whether or not there's any activity that should be considered worrisome by doing the first thermogram, the second one at about 3 months after that, and if it's stable, doing them manually thereafter.
Okay. And I think she had said, is there an inflammation concern? That was the question about getting a thermogram after mastectomy, and later on she asked, is there an inflammation concern? Did you just cover that?
I did.
Okay. Okay, maybe we'll take one more question. This is from Melanie. If one has made many of the lifestyle and dietary changes but still has an abnormal thermogram, what else can you do?
Well, I have 2 answers. If a thermogram comes back showing an abnormality, that abnormality may be the result of some prior trauma. You know, I've had people who have been in car accidents and impacted their breast and had significant trauma to the breast. And when you have that, blood vessels will come to heal that trauma. Well, once a blood vessel comes to the breast, it stays. So as I said earlier in tonight's webinar, those blood vessels don't ever go away. So we have to define abnormal. Abnormal is something that is changing, as opposed to something that may deviate from the standard of symmetry but is stable. Something that looks, let's say, and I'm not mean to use it this way, but let's suppose somebody has a box pattern and they have it year after year after year after year and it doesn't generate any heat. Well, that's their normal. So you have to define normal and abnormal in those terms. The second thing that you have to do is if the study is consistently changing and adjunctive testing such as ultrasounds and MRIs are normal, then there's 2 answers. One, there may be some pathology elsewhere in the body. For example, there may be a dental infection that's causing the breast to not be stable. You know, there may be a thyroid abnormality or other hormonal imbalance that should be looked at and addressed as a possibility. The other thing is, because thermography is so sensitive, just because next year's thermogram may be a little bit different doesn't mean that the year after's is not going to show stability.
Did you mention in that also the dental? That would maybe be one other thing to take a look at. I know that we read a statistic recently that 82% of women with breast cancer had dental infections from a root canal specifically. So that could be something to look at. I would like to see everybody doing a breast thermogram doing also a thyroid dental study, because the connection is so great.
I agree.
Okay. So I think we've gotten to just about all of the questions. If for some reason we did not get to your question, feel free to email us and or call the office, and we'll be happy to answer your question. So just to wrap up here, Dr. Getson, I'd like to thank you very much for your time and the valuable information that you presented here. I hope it encourages us all to do what feels right for us as women, as an individual, and as a collective. I think when talking about change, the way to create that is for, as a group, as a collective, to call your insurance company, talk to your doctors, express how you feel and what you desire to do as far as imaging and with your body. You have to speak up. So thank you again. On the screen you'll see our websites, our contact information. Please follow us on social networking, Facebook, Twitter, and LinkedIn. We'd love to have a positive Google review. Next month's speaker will be Ben Briggs. He's a natural compound pharmacist and owner of the Lionville Natural Pharmacy and Lionville Holistic Health Center. He will be presenting on Wednesday, March 25th at 7 o'clock. Ben will be discussing thyroid dysfunction and adrenal fatigue, an epidemic of the 21st century, and I think we touched on that when doing the thyroid thermograms. We are finding so many folks with thyroid dysfunction that the conventional blood work is missing. So that's going to be really something to tune into. So as a special thank you for attending our first live webinar, we are pleased to offer you a $25 discount on your next thermogram. When scheduling, just mention the passwords breast health. So again, I would just like to say thank you, Dr. Getson, and thank you all for participating in our first webinar. We look forward to many more, and I wish you all good night.